but approximately 25% of all patients that have urothelial cancer will develop metastases at some point. The most common sites we see are obviously local nodes first, but then for distant metastases can be liver or even bone. Lung metastases do happen as well. As it stands at the moment, systemic chemotherapy is still the standard first-line therapy, and initial responses can be really quite high, but unfortunately the duration of that response is not overly long. The median survival with multi-agent chemotherapy alone remains only approximately 15 months on average, although this is changing a lot with the newer agents, which we'll go into. And 5-year survival still remains quite low. But the fact that it's even 15% is sometimes surprising, and I think we probably all see the occasional patient who we think is probably cured despite having distant, usually nodal or only small lung metastases at diagnosis. So I can think of 3 or 4 off the top of my head who are 5 years later and have never recurred, that I'm still seeing every 6 months, despite the fact they had nodes even up as far as their suprapubic diagnosis. Immunotherapy is becoming a much more important additional option in these patients, which I'll go through in detail, and is a subject of a new agent that's just made it onto the PBS actually this month, which I'll talk about, and you may start to see patients being treated with. Just to mention in passing, we tend to treat all metastatic urothelial cancer the same once they've spread. So all the treatments that we use are referring to upper tract urothelial cancers as well, although the evidence is based on that's seen through the bladder cancer trials. There's not a lot looking at specifically upper tract urothelial cancers. So in terms of whether someone is, fit for the treatment, how long we think they're going to live for does depend on a few things that help determine their prognosis. So obviously their overall performance status, and I'll show you a little table coming up of how to measure that, but how symptomatic somebody is, how fit and active they still remain, will certainly help determine how long we think their prognosis is and how they'll tolerate treatments. The presence of visceral metastases, so that would be lung, liver or bone, is a poor prognostic factor, whereas nodal only disease, even if it's up as far as the neck, is actually still much better prognosis than those with visceral disease. And the worst outcomes are seen in those with bone or liver metastases and a poor performance status. So they're already quite frail when you meet them, very symptomatic, being a lot of their day kind of resting. Their median survival is thought to be about 4 months, and they're often not even fit for any therapy at all. So what's the first treatment we normally give these patients? Platinum-based chemotherapy is still the preferred initial therapy. And as I mentioned before, a small proportion with distant metastases or nodes in the nodes of lung may actually be cured by upfront platinum-based chemotherapy. And you've probably seen patients on both cisplatin or carboplatin, and those regimens that incorporate cisplatin actually have a higher response rate and a higher survival, but also do require a slightly fitter patient to tolerate them. So what do we look at when we're defining whether someone's actually fit for systemic therapy? And when we say systemic therapy, we're kind of talking about anything that's intravenous or oral that is obviously circulating widespread in the body, as opposed to surgery or radiation being more local therapies. So look at their age, how fit they are in terms of their performance status, so their functional status at home, their other health issues, organ function, especially their renal function. And it's very important. However, it's very, very important to determine whether their renal impairment is due to something pre-existing or whether it's just related to obstruction from tumour. And that's when we would certainly get their urologist still involved. If we think that we can improve their renal function by putting in a stent or an nephrostomy, then that might allow us to actually give much more effective chemotherapy, even if it's short term and can be removed at the end. We don't formally do it, but we'd really wish we had more input from the geriatricians in terms of a cognitive assessment, because sometimes this actually is unmasked by their chemo. You think they're doing quite well, and then you go and give them a little bit of chemo and suddenly they can become confused, and a lot of their underlying, perhaps hidden cognitive impairment can become quite evident during their chemotherapy. So you will read a little bit about treatments for bladder cancer as being determined by this theme of cisplatin eligibility. And a lot of trials are done based on this. And we make treatment decisions based on whether we think someone would be fit enough for cisplatin or not. And there's very well-defined criteria explaining exactly what those things are. So performance status of 2 or more. And the next slide, I'll just show you what the performance status is. If their creatinine clearance is poor, which is not something just due to tumour obstruction, if they have significant baseline hearing loss, they already have a peripheral neuropathy. So, for example, people that already have diabetes, a lot of our patients have other health problems and might already have a peripheral neuropathy. New York Heart Association class 3 heart failure, which we don't often see, but occasionally we have someone with very bad heart disease who might not, the fluid load predominantly being the problem with cisplatin, because you need to give a lot of fluids with it to avoid renal impairment, and that fluid load can't be tolerated in people with bad hearts. And if none of these above features exist, then really we should try and give upfront first-line cisplatin-based chemotherapy. So this was just to remind people of what the ECOG performance status is. I'm not sure if you can see my cursor on there, but 0 is basically asymptomatic, fully active, independent of all their activities of daily living. As a lot of patients we see are probably ECOG 1 in terms of they're a little bit restricted, but they're fully ambulant and they're able to do really most of their usual activities. Once you get to 2, 3, and 4, it's relating to how much of the day they spend awake and active. So if they're up and about more than 50% of the day, they're ECOG 2, and they're getting worse with more and more time spent in bed and resting. If someone is unfit to have cisplatin up front, we could switch that to another chemo drug called carboplatin, or even think about regimes that don't have platinum in them at all, but the response rates are much poorer. In a lot of other countries, they allow access to immunotherapy up front if you can't have cisplatin, but in Australia, they're very clearly in the PBS rules stated we have to at least try platinum-based chemotherapy first, even if it's one cycle, prove they don't tolerate it. We can then access the immunotherapy agents, but we can't give it as the first treatment and still receive PBS funding for them. So what are the preferred first-line chemotherapy regimens? And I'm not sure with the audience, there's probably some people that are oncology nurses and some that are urology nurses, but most chemotherapy and immunotherapy is intravenous, but given as an outpatient in a chemo suite at a hospital. The main chemotherapy regimen we use is a combination of 2 chemo drugs called cisplatin and gemcitabine. This is just giving the doses in case anyone was interested, but I won't go into detail of the doses. But usually this cisplatin and gemcitabine is given on 21-day cycles for approximately 6 cycles. We would normally give 2 or 3, assess their tolerance, and then repeat some imaging. And if they have pretty much stable changes on their scans, so that means tumours have not significantly increased in size, or they're in fact responding and shrinking, we would probably go for another 3 cycles and then repeat a scan at the end of that. If someone is they have to be quite fit, is the second regimen on the page called MVAC, and the MVAC just stands for the first letters of the 4 chemo drugs that are given together: methotrexate, vinblastine, doxorubicin, and cisplatin. And as I'm sure most of you can appreciate, giving 4 chemo drugs all at once is pretty hard going. They do require GCS injection support, so that's basically the white cell booster injection that you give to try and maintain their immunity to allow the chemotherapy to continue. And that can be given either 2 weekly or 3 weekly for up to 6 cycles as well. However, there has been, and previously until the last few years, MVAC was kind of the gold standard worldwide, even though it was very toxic. So there was then a phase 3 trial done looking at those 2 regimens to see could we get away with something that's less toxic, but still have the same outcome. And this study had 405 patients enrolled, and they found that the 2 agents, cisplatin and gemcitabine, were pretty much equivalent to the 4 agents together, with a response rate and time to progression, so time to worsening of their scans, and the overall survival were pretty much equivalent. But was found to be a lot less toxic given 2 agents rather than 4, not surprisingly. So really worldwide, there's been a big switch to giving the cisplatin gemcitabine by the majority of clinicians, apart from some countries that kind of stick to their guns and want to stay with MVAC. As I mentioned earlier, if they do have those contraindications of cisplatin, like so poor renal impairment, or just the poor performance status comorbidities, then we would switch that to carboplatin with gemcitabine, which is a little bit less toxic and with less effect on blood counts. So what are the main toxicities of chemotherapy? They are reasonably similar across a wide ranging number of the chemotherapy agents, but their severity varies. So the things that we see very commonly with any chemotherapy is nausea. That's getting better and better controlled. there's been a whole heap of new anti-nausea medications in recent years that have really changed the game with that. Even since I did my training, you very rarely see someone who comes back and says they've been vomiting, after chemo. A lot of people have some mild nausea, but they get sent home from chemo with a whole regime of, medications to take to try and prevent nausea, but then also to treat it if they get it outside of those medications. Everyone gets some taste changes. They usually say it's like a metallic taste in their mouth. Biggest concern for obviously the doctors and the nurses is the effect on their blood counts. And this can be any one or all three of low white cell count with neutropenia, anemia, or thrombocytopenia. Things that the patients complain about the most is just fatigue, that it just gets, the fatigue can sometimes be so debilitating they can hardly do anything. And it gets worse the more chemo cycles that they have. So that most of the other side effects don't get worse and worse and worse as you go through the treatments, but fatigue, I warn everybody, that will get slightly worse after each cycle. And some patients can't get beyond kind of 4 rounds of chemo because they're fatigued so bad. Because chemo kind of works by killing lots of rapidly dividing cells in the body, the lining of the mouth and the bowel is always dividing, so you can get some diarrhea from most of the time from some ulceration in the bowel, and also mucositis, so ulcers in their mouth. The platinum agent specifically can cause electrolyte disturbances, so some people get high renal losses of magnesium, potassium, or calcium. And the chemo agents themselves can cause renal dysfunction. So we are sometimes left in a bit of a quandary of, is it chemo-induced renal impairment? Are they progressing through their treatment and getting renal obstruction? So we're quite frequently doing, CT, IVPs, scans of the abdomen to kind of check whether they're obstructing or whether it's related to the drugs that we're giving them. And people will get hearing loss from cisplatin, which is much more important in the older men who might have had occupations where they had occupational hearing loss. We kind of warn them that this is very likely to happen, but most of the time it's kind of one of those things it might happen, but what do we do if it does, is you really kind of assess how bad it is and probably just need to push on despite the fact they're getting the hearing loss if they're getting a good cancer control with a cisplatin. The additional side effects with giving the 4 agents rather than 2 is that all those above side effects are worse, but also they're much more likely to get a peripheral neuropathy, and they do get hair loss with the doxorubicin from that, whereas the cisplatin gemcitabine, they'll get a bit of hair thinning, but not to the point where if they walk down the street or had lunch with their family, they would know they're having chemo. So they're quite like that. It's not a visible thing that people know they're a cancer patient, know they're having chemo, because they don't lose much hair with the cisplatin gemcitabine. So beyond chemotherapy, what's kind of the next step? And immunotherapy has really taken over in so many cancer types now as very effective agents. And immunotherapy, for those that are not fully aware, is defined as the prevention or treatment of any disease, not just cancer, with substances that stimulate the immune response. So immunotherapy is used for other autoimmune conditions as well. So it's used for rheumatoid arthritis and inflammatory bowel disease. The agents that we use and have been tested in urothelial cancer include pembrolizumab, avelumab, and atezolizumab. They are all intravenous, so we often get patients going, can't I have something that's oral? They think that by not having chemo that they don't have to be, coming to a hospital in a chemo suite, but unfortunately these agents are still intravenous as well. There's 2 ways in which we may use immunotherapy. The first is maintenance after chemotherapy, and I'll go through this in more detail on the next slide. Or in the second situation is they've had chemotherapy first, either the cancer hasn't responded and it's grown during their chemo, or they've had chemotherapy with, maybe a partial response, so things have shrunk but not disappeared, and then on their follow-up scans, it started to grow again. You can then access immunotherapy in that situation as well. So I will touch a little bit on immunotherapy maintenance because it's been a really big change, and very thankful to the Beat Bladder group to really push this through and help with patients writing in and supporting it, and doctors also saying how important it is to have these options available. So avelumab, or it's licensed as Bavencio, did obtain a PBS listing finally as of the 1st of October this year. The PBS indication is for maintenance treatment in any metastatic urothelial cancer, so not just bladder, that has not progressed after first-line platinum-based chemotherapy. So that can be that they had chemo and their scans look stable. They don't have to have had a great response. They don't have to have the cancer completely disappear, as long as it's at least stable, so their scans have not worsened, or they've had a partial or a complete response. After a minimum of 4 cycles of chemotherapy, they're allowed to access avelumab as maintenance to try and maintain that good response they've had to their chemo. This is the Javelin Bladder 100 trial that was that this evidence came from, and this was a lot of Australian sites were involved in this, and I had patients on this trial. So hopefully you can see my cursor, but on the left of the screen, it's just really listing what the eligibility criteria were. So as I mentioned, metastatic urothelial cancer, can't have had worsening of their imaging based on any platinum-based chemo, didn't have to be cisplatin. And obviously people that did not have a very significant underlying autoimmune disease that would make immunotherapy dangerous. And they were then randomized in a 50-50 fashion to either avelumab maintenance or best supportive care. And that would be what we always did, or we still do with a lot of patients now, was basically recovering from their chemo, allowing them to get on with life and just kind of watching their scans to see, was it better to have maintenance, which is really early immunotherapy, or later, based on, or waiting for their imaging to get worse and their cancer to get worse later. So just to walk you through this slide, it's really kind of showing across the x-axis this overall survival time based in months, depending on whether they had best supportive care or immunotherapy. And as you can see on here, those that just then went on to surveillance after the chemotherapy had approximately only a 14-month overall survival. But those that then went on to avelumab maintenance actually had a very significant improvement in the overall survival, up to nearly 2 years. As always happens, trial results come out and we know about them for ages before the PBS agrees to pay for it. But we have had an access program, which is the drug company giving us free access to avelumab for probably the last 12 or 18 months. So we've had patients on it despite not having the PBS listing yet. But luckily, as of October, they've all now transitioned over to PBS supply. Sorry, slide just was not advancing. So what are the adverse reactions? So this was actually a good way of looking at it, because in the first column, it's those patients that had received the avelumab maintenance versus those that only had best supportive care. The main things to point out is that there's significant fatigue, so 35% versus 13% for those that were not having treatment. There was an increase in musculoskeletal pain, obviously increased rashes, because it's autoimmune, you're stimulating immune-mediated illnesses, you can get like an autoimmune rash. Most common thing we see is probably fatigue and GI upset, so either diarrhea, a bit of nausea, and basically immunotherapy, and I think I've got a slide coming up, can affect any organ in the body to cause inflammation of it if you get ramping up of the immune system. So who do we give maintenance therapy to? So I think now that the PBS listing is there, we really have an obligation to offer it to any patient who has completed their first-line chemo, who has stable disease or better on their scans. I think we need to tell people about it. Not everybody's going to say yes. Some patients are really just ready for a break at their end of chemo. Contraindications to immunotherapy is anyone who already has a significant autoimmune disease, because we could make that worse. So if someone's requiring treatment for inflammatory bowel disease or lupus or rheumatoid arthritis, or they previously had myasthenia gravis, these are all very significant autoimmune conditions that could be life-threatening or have a significant impact on their quality of life if we made them worse. So they're the situations we might not give immunotherapy, or we might ask their treating doctor. So ask the gastroenterologist or their rheumatologist how bad they think their underlying condition is. Would they consider that a contraindication to immunotherapy? Obviously, if you had an organ transplantation, you can't have immunotherapy, or previous viral hepatitis that you could flare. They don't require a lot of pre-medication, so some antihistamines and paracetamol is all you need for immunotherapy. So this slide is kind of indicating all the things that can get inflamed if your immune system ramps up too much. So obviously really going through almost every organ of the body that can get inflamed if the immunotherapy basically overstimulates the immune system. And it's very, very hard to predict. Really, any one of these can happen in a very unpredictable fashion. So what do we do if they progress during their first-line chemotherapy and they're not eligible for maintenance avelumab? They can still get immunotherapy. It's just a different agent called pembrolizumab, or you might have heard of Keytruda because it's been so amazing in changing the landscape for melanoma, also with lung cancer. So the PBS listing for this is just a little bit different, where it says you must have progressed after a platinum chemo. So really it's, you can get immunotherapy either way. Either your scans are good and you can get avelumab maintenance, your scans are bad, you can get pembrolizumab. And this was based on a trial that showed about a 3-month improvement in overall survival with pembrolizumab. And I know that sounds like a worse outcome than avelumab, but you have to remember these patients are having second-line treatment because their cancer actually progressed. So they're already people with a worse prognosis. So the benefit is smaller. So those toxicities that I showed on the previous slide are very unpredictable. They can come on very suddenly and sometimes can even be fatal. So it's hard sometimes to consent patients to these treatments because you have to say that these things can happen, but you don't want to scare them so much they don't want to have treatment. So we are all learning very quickly about immunotherapy toxicity, and really the vast majority of the times it can be reversible with high-dose steroids that may require a hospital admission and may require intravenous methylprednisolone to turn this around sometimes. But most of the time we kind of can see it coming on their bloods or a rash, and we kind of stop early and start them on prednisolone. So we're kind of moving more into some of the trial and new drugs coming up. So what do we do after immunotherapy, or if there are contraindications to immunotherapy? So both of these drugs listed here are not yet available on the PBS. So enfortumab vedotin, which I've got in the next couple of slides, does have amazing results, and they keep getting presented at all the conferences, so there's just not a PBS listing yet. This is still intravenous. Erdafitinib, the second one, is only indicated in people that have a very specific mutation detected on their tumour, so we need to do testing for that. And if they have what's called an FGFR receptor mutation, they could have these agents, again, only available on trials. Or they can go on and have further chemotherapy, usually with different agents. So enfortumab vedotin is a very new class of drug. There's a couple of these drugs also in breast cancer, where in the top left is the little green Y-shaped upside down Y is an antibody that binds to a specific receptor on the outside of the cancer cell. That then gets kind of internalized, so sucked inside the cell, and the little red dots are tiny doses of cytotoxics, so basically like chemotherapy. So you're releasing small doses of chemotherapy, but directly into cell inside the cancer cells. The amazing thing with these kind of drugs is that you don't get a lot of toxicity from them because you're not giving really big doses of chemotherapy to affect the rest of the body. But you are putting a high concentration directly inside the cells that have these receptors on them. Next slide. So it attaches to what's called an anti-nectin-4 antibody on tumour cells to release this cytotoxic inside. There's a phase 3 trial, which was called the EV301, which used enfortumab vedotin versus just second-line chemotherapy with whatever agent the specialist wanted to use. And the response rates have been quite amazing. And this is in people that have already been through 2 types of treatment before. They've had chemotherapy, they've had immunotherapy. They're still getting a 40% response rate to this drug. I personally have I'm very passionate about this drug because I have the last remaining patient in Australia who's still on it, who progressed through platinum and immunotherapy and had a complete response within 2 doses of enfortumab vedotin, and is alive and well and racing national yacht races 3.5 years after he started the treatment. So I think it's amazing, but I'm probably a little bit biased because I have seen such an amazing outcome with it.
5 minutes, Patty.
Great, that's perfect. Another very similar drug, which has actually been tested far more in breast cancer, and it's a similar kind of drug where it's an antibody with some tagged cytotoxic to it called sacituzumab govitecan. And that does a very similar thing, just attaches to a different kind of membrane protein on urothelial cancer and releases the equivalent of irinotecan, which some people might have seen used in bowel cancer directly into cells. This is very early. I haven't seen it used in Australia yet, but I know that there are some oncologists that are looking for it for patients that have failed everything else. The cost, however, I think is about $120,000 a year to pay out of pocket for it with no access at the moment. Erdafitinib is the only oral agent that we can use, and I've had a very little bit of experience of this in trials. The main reason that makes it really hard is that you have to have this tumour testing that takes 4 to 6 weeks to get results back, and only 12% of patients with urothelial cancer will even have the required mutation, the FGFR mutation, that means they might actually respond to the agents. But of the people that do have the FGFR mutation, the response rate is thought to be 30 to 40%. If you can't get access to any of the trial drugs, there are a whole heap of different chemotherapy agents that we can try. However, my first line there showing that response rates vary, but they're only 10 to 30% at absolute best. So they're really only indicated if someone's very, very passionate about having further treatment and they have a good performance status. Do you think they can tolerate more treatment? And there's a range of agents used, mainly taxane, so paclitaxel, nab-paclitaxel, and docetaxel, and binflutin is used overseas, not licensed in Australia. I can't say that I've used any of these anytime recently. We've managed to find a trial or something different for most patients. So this might not show up very well on your screen. It's really just a flow chart of what to look for in terms of what's their baseline performance status like and their renal function. Based on that, yes or no, do you go for platinum-based chemotherapy or not? What happens when they progress? So going down to the immunotherapy usually is our second line treatment. And then third line, as I kind of said, is other chemotherapy agents, looking for trials, targeted agents. So in summary, advanced bladder cancer does have poor outcomes, but our overall survival is actually increasing with all the new treatments we have available. There's certainly an explosion of new drugs in urothelial cancer. And after many years of not many changes to treatment, there seem to be new drugs coming about and patients are living longer. We do see a small percentage of patients that have very long-term disease control or may even be cured by some of these agents. And immunotherapy having an increasing role to play either in that maintenance setting after chemo or when their cancer gets worse. And it's very likely that some of those new agents, enfortumab vedotin and erdafitinib, are targeted agents that are likely to increase in frequency, and hopefully PBS listings will not be far away, at least for the enfortumab vedotin.